now I'd like to call Dr. Ganesh V. Raman, Head of the Glaucoma Services, Arvind Eye Hospital, Coimbatore. Sir, for your talk about the role of SLT.
Thank you.
Ganesh, just a sec. Welcome Dr. J.S. Bhalla also. He is a member Scientific Committee AIOS and also heading the glaucoma service at DDU Hospital in Delhi. And he'll be inviting the next. Kiran is here. Please come forward. Go ahead, Ganesh.
Thank you. Thank you, Chairperson. I would like to thank AIOS for providing me this opportunity to speak to you on the current role of SLT. No financial interest in any of the products or devices discussed here. So the SLT now, if you go through the literature, you'll find that there are nice guidelines of UK and also the US have listed as the first line of treatment for primary open-angle glaucoma. And the main advantage of that is that it removes the patient factor. Like our mentor, Dr. Alan Robin mentions, most patients miss some drops, some miss most drops, and few miss all the drops. So this is when I visited you in 2014. It's been 10 years since. And now we have the new devices which are coming to vogue. So this is a small study which we are conducting now, and I'll just share the results with you, brief interim results. So this is a 6-month recruitment and 1-year follow-up. Objective is to study the safety and efficacy of SLT. And if you see, the mean baseline intraocular pressure was 24.76 before medication, and the mean visual field deviation was, MD deviation was 5.76. All the patients are faking, all 30 of them. And at the end of 6 months, you have intraocular pressure of 18.6 millimeters of mercury. That's quite significant drop, almost 21% drop. Some of the patients are on medication. This is, of course, as I mentioned to you, interim analysis, so we'll be looking into the data further. But suffice to say that SLT works very well in open-angle glaucomas and ocular hypertension. This is the study group which we had included for this study. And this is something similar to what Dr. Srishti Raj and the group has published from the PGI Chandigarh. They did the SLT for angle closure. And I think now you also have the 5-year data of the same cohort. And you can have a look that the intraocular pressure reduction is almost 28% IOP reduction from baseline. So that's quite significant. So with no adverse effects, side effects. And similar to the juvenile glaucoma population, which was treated with SLT from the AIMS group, they also had a mean untreated baseline IOP of quite high, 36 millimeters. And pre-laser, the IOP was 25 millimeters of mercury. And after the laser treatment, the intraocular pressure fluctuated between the range between 10 to 22 millimeters of mercury. And with patients with normal open angle, they had a better response as compared to patients with angle dysgenesis. So previously, we used to have the flash pumped Nd:YAG laser. So it was a photo disruptor that could also function as a dual function laser. And you could use the double frequency version of it and do the SLT. The unfortunate thing with that was that the energy delivery was about 20%, plus minus 20% of the expected. Whereas now we have the diode pump neodymium orthovanadate laser. It works as a photocoagulator at the 577 nanometer green laser range. And this also has a dual function. And you use this, it has a 52 fast spot targeting the pigment epithelium in the trabecular meshwork. And the energy delivery of this is about plus minus 5% of the expected. So this consistently delivers the same amount of energy as compared to a flash pump. And you could always cross-subsidize these machines. You could use the photo disruptor for laser iridotomy or the YAG capsulotomy, whereas the photocoagulator, you can use it for iridoplasty or your pan-retinal photocoagulation or your even slit lamp-based transscleral cytophotocoagulation, or even for suture lysis. So what are the preferable prerequisites? You should have a good gonioscopy. This is not just for MIGS, even for SLT, you should be a good gonioscopist. And 50% of angle closure, 50% of eyes in our scenarios are actually angle closure. So it's very important that you pick up the correct patients for the procedure. Treatment-naive patients are the best. So we prefer to stop all medications before we do SLT. And after SLT, we consider stopping all the medication. We don't even give lubricants or NSAIDs. We prefer phakic eyes with early POAG or ocular hypertension. And we should also expect a delayed response to treatment for about 4 months. And you could have intermittent fluctuations in the initial 2 to 3 months. The main advantage of the procedure is that it can be repeated. So after about 3 months, if we don't see a response, if we see a suboptimal response, we can go ahead and repeat the procedure. So in conclusion, SLT should be considered as a first line of treatment in early primary open-angle glaucoma ocular hypertension, and can be considered in selective secondary open-angle glaucomas as mentioned in the literature. And the present technology allows for cross-subsidization which can benefit glaucoma patients and their eyes. Thank you very much.